Good evening, everyone. Delighted to have you with us tonight, Dr. Brooke Vandermolen, who I said was talking last week about the fact that I knew the speaker when he was studying immunology. I seem to remember I've known tonight's speaker when she was deciding to study medicine.
Yes, and also immunology.
And also immunology.
Immunology.
And it's wonderful to see what happens to all these people who do immunology, and that they I hope they've acquired an in-depth understanding, which is useful to them. Brooke is now working as an ST3 in obstetrics and gynecology. She's blogging and medical writing, and she's going to talk to us about the very important subject, and the major subject, in fact, COVID-19 pandemic, women's health, and using social media and medicine in relationship to that. So I hand over to Brooke.
Thank you so much, and thank you very much for having me on tonight. I thought it would probably be a few more years before I was prestigious enough to speak to the JMA, so I really do feel honoured to have the invitation. So for anyone, I guess, that doesn't know me, I am, as mentioned, I am an obstetrics and gynecology trainee. So I trained at UCL. I did my IBSc in immunology there, and then I have been working and training in obs and gynae in and around London. So I am currently at Barnet Hospital. I've managed to turn my last year and a half of training into 4 years, my previous year and a half of training into 4 years, where I've been at Barnet because of having a couple of babies along the way. So my training has already been prolonged slightly, and in the meantime, I have been doing some things on the side, which I guess, yeah, as I summarized here, is as a women's health blogger and medical writer. But I will go into a bit more detail about these things that I do later on. This is just a little outline of what I thought would be useful to talk about. I'm also very, very happy to take questions on anything. I will talk to start with about COVID-19 and how it has affected women's health. So both from a gynecology perspective and also particularly in maternity. I'm mainly just going to kind of cover headline issues, which I'm sure many people are aware of, but some of the things, you know, we kind of take for granted, and I'll just go into how women's health has been affected. And I will touch a little bit on some of the media coverage of things like pregnant women and vaccinations. And then I thought it would be interesting, just given the pandemic and everything that has been going on. I think we have all had to adapt in so many ways. We've adapted every part of our life, but also as doctors, I think we have adapted to communicating in different ways. I'm sure many of the people on the call have been doing telephone consultations and Zoom consultations, something that was probably unimaginable, you know, a year and a half ago. So another area I think that we have been using more and more is things like social media. So I wanted to talk a little bit about why doctors might use social media, why I use social media and how I use social media, and a little bit about the guidance and what we need to be aware of as doctors, kind of doing anything on social media, and what guidance currently exists. And if you're interested in kind of doing this a bit more, some of my tips for getting started. But yeah, as I say, happy to take questions on kind of any of these things because it's quite a wide remit here. Okay, so first up, when it comes to COVID-19 and women's health, I have to say the RCOG have really surpassed themselves. They've been fantastic throughout the whole pandemic in terms of providing guidance very early on about, well, even though we didn't know very much and the guidance changed a lot since it started coming out, they were very quick to put together, accumulate all the evidence that was there for basically everything around women's health. So their website has been fantastic. Their guidelines have been really excellent and updated regularly during at the start of the pandemic. In the first lockdown, they were kind of being updated almost probably every 2 weeks. Now it's been less frequent, but also the guidance has been changing less often. So if in doubt, if you're looking for anything really relating to women's health and COVID-19, I would definitely keep up to date with the RCOG website. They also have an ability to sign up for their kind of their emails, so you also get alerts when new guidance is released, because, you know, I'll show you some of the new guidance even released in the last couple of days. So First of all, gynaecology. This has been, I guess, a little bit less controversial, so I thought I would start there. But it's so important how COVID-19 has affected many aspects of gynaecology. Of course, cancer services. We have talked about cancer services, you know, in other specialities, and of course, the gynaecology services have been affected as well. Importantly, things like smear tests. In the first couple of months of the first lockdown, there was, you know, a pause in most places in terms of smear tests. People were still encouraged to see their doctors if they had symptoms of cervical cancer, but there was a pause in the program, but that was quite quickly restarted. However, the kind of legacy from that will still probably take us a very long time to get over. And we don't fully know yet the effects of that, as with everything with COVID-19. You know, you can see an image that I've put up here from the Eve appeal, that nearly 1 in 3 women didn't attend their cervical screening test was because of COVID concerns. And so there will definitely be a huge number of women who missed their smears just because of fear that it wouldn't be safe, rightly or wrongly. But of course, they are absolutely going ahead. And so, yeah, I think it's a really important thing to kind of be aware of. I know that some of the GPs in London have been trialing this new service of people taking their own smear tests at home, which anyway is fantastic, and even more so to try and get access to those people who we may have been missing out because they didn't feel comfortable, or they were shielding, or for one reason or another, people aren't going. And so I've kind of put a tick here where the service is kind of running now as it should do, even if people aren't aware that they're running as it should do. When it comes to things like postmenopausal bleeding and the urgent 2-week wait type cancer services, again, those should be running now as normal. We are running our cancer clinics as normal now, although the problem is some people don't necessarily come via a 2-week wait pathway. People might go with abnormal bleeding, which may well be a symptom of cancer, but unfortunately, our waiting times, I was looking over with one of my bosses the other day, just for the surgeries that we need to get through alone is probably going to take us 5 years, up to 5 years. And this, you know, we have crazy waiting times for our outpatient clinics. So things that are not coming through an urgent pathway will be a very long time before we get to them. So that will also no doubt have an effect on how we are picking up cancers. Hopefully when we are able to start seeing patients on a regular basis physically again in the next kind of weeks to months, we will be, you know, re-triaging the referrals, but it's not always easy to pick up on things that we would otherwise like to have picked up on. With such long waiting times. So yes, these services, postmenopausal bleeding and 2-week wait for gynae surgery should be running as normal, but there are some caveats to that. There is an ongoing trial, the COVID surge kind of cancer trial, which has been recruiting but hasn't yet reported its data. So that applies to all kind of different cancers and how they're being affected by the kind of COVID surges and lockdowns. So it'll be very interesting to see what those results show. But, you know, I'm sure we won't be surprised when we say that there will be a huge number of excess deaths from cancer, both, you know, from people who didn't have their cancers detected early enough, didn't have their treatments early enough for various reasons. Then moving on to kind of benign gynecology, again, there has been disruption, some of which has been now kind of rectified. At the start, there was a lot of difficulty in getting access to things like HRT, so for people suffering with symptoms of the menopause, people that were having patches and injections on a regular basis had difficulty accessing that, when at the start, you know, a lot of GP and nurse services were stopped completely. Again, that should be more or less back. There shouldn't be huge delays, but there may be in some places. When it comes to contraception, we stopped again offering a lot of different types of contraception, anything kind of intrauterine coils being inserted, coils being removed. I had a lot of women coming to me saying, you know, they were desperate to try for a baby, but they can't get anyone to even take their coil out, something that takes, you know, 2 seconds and doesn't require much training. But at the start, that was a real issue. Again, all the sexual health clinics should be running as normal, and GPs are also offering contraception services. So that should be kind of running, even, you know, as we are now in a lockdown, that should still be back to running kind of as normal. Another aspect that was challenging was pessary changes. So these are all kind of, you know, not huge problems, but they're just things that require women to seek, you know, medical advice or just interact with medical professionals on a regular basis, and was really disrupted by COVID-19. So even something as simple, again, as a pessary change was disrupted. And the problem with pessary changes specifically, the age group that tends to have a pessary inserted would be women with a prolapse, and they tend to be the women in the much older age groups who may not be suitable for surgical intervention, or who may not want to have surgical intervention, and they have their pessaries in, and usually we change pessaries every 6 months. Some of the newer types of pessaries, we actually only take them out after 6 months, wash them and reinsert them again, the same one, so we don't always have to replace the pessaries. Benefit of that being that at the start a view was taken that for many people, especially those in the older generation who couldn't get out the house, who were shielding for a long time, just extended how long they had their pessary in for, and that was very unlikely to cause any harm. But even now, we still have issues with, you know, we don't have our routine appointments in hospitals available. And again, it's really not necessarily suitable for somebody who might be vulnerable and elderly, and also who may not have the support of someone to bring them into the hospital. Many GP practices offer this ability to have, you know, pessary changes, and some GPs also will do it on home visits as well. So there are ways of getting around it, and we have all become better at adapting, you know, as the pandemic has gone on. But I would say this service, you know, probably still isn't back to normal. And again, the wait for a urogynecology appointment will be very long, because we are not doing any routine urogynecology appointments at the hospital. We're only doing some telephone appointments, but no in-person, face-to-face at the moment. So yeah, that's not really back to normal yet. Fertility service was a massive problem that was affected at the start. You may have been aware that although kind of the societies basically said stop all fertility treatment, and there was a bar on fertility treatment for about 4 months, when we just didn't know what the effect of COVID-19 would be on people, you know, in early pregnancy, where we had really no data at all, and they didn't know if it was safe to advise anyone to try to get pregnant. And also, of course, you know, having fertility treatment requires people to come in and out of a clinic nearly every day for a month or 2 months, having scans, blood tests, and injections. And again, it was felt that the kind of risks both to the healthcare professionals and to the women was outweighed by any possible benefit of being pregnant. The, you know, massive downsides to that, you know, for so many reasons, but especially we have, you know, a lot of women who may be approaching the age of 40, who may be kind of coming up to their last chance. People turning 40 during the first lockdown, it was, you know, when you are going to be eligible for NHS treatment and then suddenly you're no longer eligible. It was, you know, it's really, really upsetting for people, really disheartening, and people having to go down other routes. And eventually the ban was lifted, and now fertility services are running as normal. They should be available. The only downside is in many clinics, you know, partners may not be able to go to all the appointments where they otherwise would have been present for support. And the support in fertility treatment is really important. But I think, you know, people are delighted that their fertility treatment can happen. So then the kind of final aspect of gynecology that has been affected was early pregnancy. People coming in with bleeding in early pregnancy and problems such as that. At the start, again, there was really very, very few people who were offering any kind of early pregnancy scans unless in an emergency. Now we are back to running our normal early pregnancy clinics, whereby anyone with any kind of real issue in early pregnancy can come into the unit and have a scan if required. In some places now, partners are also being allowed to attend with them, which is great, because one thing we know, for example, for someone who has had recurrent miscarriages, that actually support in early pregnancy makes a difference in how likely they are to proceed with their pregnancy successfully. So even just being under an early pregnancy clinic with the support of a partner makes it more likely that you will avoid a miscarriage after you've had 3. So that's kind of good news that they're back to functioning close to normal there. The only caveat is we're not really offering any reassurance scans. So for people who may just want to check, just want to see that everything's okay and they're sort of 8 weeks pregnant, we're not really offering that kind of service, because it still should be on a very urgent basis only. So which is why I've indicated there that we're not quite back to running it as normal. This was just a piece of guidance from the FSRH, which was released during this. This is actually, yeah, a couple of days ago, released to cover the third lockdown about what sexual and reproductive healthcare should be provided. They more or less said everything as normal. One of the additions since the COVID-19 pandemic is that we are, you know, as again with everything, offering a lot of telemedicine, but abortion services are also now available via telemedicine, which has made a huge difference to many women who, especially in the first lockdown when they couldn't see anybody and all abortion services were stopped, we were able to speak to them by phone and prescribe medication so that they could have their terminations at home. So that's been a big change. Okay. I'm sure for any of you who have interacted with anybody that is pregnant, whether it's a family member or a patient over the past year, you know, it's been such a concerning time for anyone going through this because there are just so many unknowns. So first of all, when you are conceiving, this pandemic has massive influences because many people have chosen to delay their family because they want to wait and see what's going to happen, maybe wait to receive their vaccine and then conceive afterwards. Again, worries about miscarriage, which I mentioned earlier. Now, at the start, we really didn't know. We extrapolated slightly from some of other similar viruses to suggest that we didn't think there would be an increased risk of miscarriage, so from viruses like SARS. And at the moment, that seems true, although we don't have any further data yet published to confirm. But at the moment, we don't think that there is an increased risk of early miscarriage. Anecdotally, from our unit, we did see a big increase in second trimester losses since the pandemic has happened. So we don't obviously fully know exactly why that is. And that was in people both with and without symptoms of coronavirus. So we don't know whether that is just because of a change in services or what has caused that. And hopefully the data on that will come out over time. But at the moment, the advice is we don't think that having COVID-19 increases the risk of miscarriage. Again, COVID-19 in general has massively affected the provision of pregnancy support. I put it there early, but actually in general, all the way through pregnancy, most people will tell you that their experience has been, they have felt much less supported. That is because when you become pregnant, normally you go from kind of, you know, being as a healthy woman, maybe seeing your doctor once a year, maybe even less than that. You become pregnant, you're seeing your midwife, your doctor every couple of weeks for the whole time. And actually during the COVID-19 pandemic, most people have not had any face-to-face appointments at all, apart from their scans, which would be at 12 weeks when they have their bloods taken at the same time to avoid another visit. And then they might see again, a sonographer at 20 weeks. They'll have all their appointments with their midwife, often by phone, and then only maybe see their midwife face-to-face in the kind of third trimester. And that has had a massive impact on how supported people feel, about how people present or don't present with symptoms and problems during their pregnancy, because sometimes people just save it up, just, you know, they don't think it's worth mentioning over the phone, and because they haven't been seen face to face, they don't necessarily bring up even, you know, seemingly trivial things like pelvic pain, which people really suffer with. They may not feel like it's necessary to speak to somebody over the phone about that, but they might have mentioned in passing at an in-person appointment. So people feel much less supported. It's much harder to make things like birth plans over the phone and generally to prepare for birth. So all the other aspects as well around pregnancy that people miss out on. Having a baby shower, having your mum see your bump grow as your, you know, all those kind of changes that happen to you that you normally share with the people around you at this kind of pivotal moment of your life. A lot of people really feel that that's been stolen from them. Being around colleagues and kind of sharing that excitement of leading up to maternity leave and then going on maternity leave. It's not the same when you've kind of been sitting at home for the last 20 weeks and they say goodbye to you on Zoom. I think a lot of people, again, feel that they kind of miss out during that. Women are very understandably very worried about the risks of coronavirus on pregnancy. Again, I think this is something that the data is going to change in the future from smaller studies. But again, the current RCOG advice is that we do not believe that women that catch coronavirus in pregnancy are at increased risk of complications. However, we are now saying that they are likely to be more at risk of developing a more severe form of the disease if they contract coronavirus in the third trimester, although the risk is still very small. again, anecdotally, at our hospital, we have seen a huge number of women very unwell in their third trimester, requiring delivery of their babies between kind of 28 and 32 weeks often, and we've had, you know, even in the last couple of weeks, several women going for ECMO, so not just needing ITU and ventilation, but actually going out for ECMO as well. So I think that we have been very positive about the risks of coronavirus and pregnancy so far. The last data that actually I'll show you that in a few slides of some of the studies that have been published so far. This is just about other worries that people have. Yeah, again here, the risks of coronavirus to the mother. So whilst there is probably not really any increased risk of coronavirus on the pregnancy itself, we do a follow-up growth scan 4 weeks after someone has had a confirmed case of coronavirus, just to check that the baby has continued to grow normally. And then there are risks, obviously, of coronavirus to the mother. There was a lot of concerns, especially around breastfeeding at the start, but we are understanding more and more that it is safe to breastfeed, that you'll be passing on some passive immunity, especially if you did get COVID-19 earlier on in your pregnancy and you already have some antibodies, that you'd be passing those on to the baby. The cases of transmission where babies have turned out to be positive have come from all the different sources really now. We know that mother to fetus kind of across the placenta transmission is now possible, as well as most likely via the breast milk. So we have to kind of advise all of these things. However, we do still consider that even if someone has coronavirus, in the UK, we still advise that it's safe for them to breastfeed their baby if they wish to do so. And then there is a lot of worry around coronavirus, pregnancy, and vaccines. And I'll go into that a little bit more in a second. So this is the kind of the main study that we have got at the moment in the UK. This is UCOS, and they published this data in June 2020. So it was an interim study assessing, you know, who has come into hospital in pregnancy in the UK. So you can see I've just kind of copied and pasted the data here, but 4.9 per 1,000 maternities. So it's still very rare where people actually needed to be admitted to hospital with the infection in their pregnancy. 56% of those admitted to hospital from BAME backgrounds. And that was a very, very significant finding. So we already know in general in pregnancy that women who are from a BAME minority group we used to say 5 times more likely. I think in the most recent release was 4 times, but either way, there's still a huge discrepancy of people, how they are more likely to die during pregnancy if they are from a BAME background, and again, even more so in COVID. 69% of those admitted were overweight or obese, so probably reflects similarly in the non-pregnant population. 41% were over the age of 35, 34% have pre-existing comorbidity. So again, these things are all kind of to be expected somewhat. Then yeah, so of this population, 73% gave birth at term, but that's pretty significant that 27% of them delivered preterm. 10% needed respiratory support, which again is pretty high for young, fit and well women coming into hospital with an infection, to 10% needing respiratory support, and 1% of the women died. And then they also had 5% of infants that tested positive for COVID. So this was quite a shocking study when it came out in June. UCOS have continued to collect data and hopefully are due to report again soon, but they haven't yet reported an update on that. So, you know, we're kind of about 9 months out. So I'll be interested to see next. And UCOS are also observing and collecting data on pregnant women who are receiving the COVID vaccine. So, you know, all of us would love to know, is it safe to give this vaccine in pregnancy? You know, we are used to vaccinating pregnant women. We give them the flu vaccine every year. We give them the whooping cough vaccine as well during their pregnancy. However, we need to show if it is in fact safe. And so UCOS are collecting this data. So they're just collecting it from this month to next month. And then hopefully we'll get some extra data from that. For any of you that do read Hebrew, which I don't, Israel have released their own updated guidance on COVID-19 vaccination in pregnancy. And they are basically now advising that there is no known harm of having a vaccine, having the COVID vaccine of any form in pregnancy. They stop short of recommending it to all pregnancy, but it is available to all pregnant women to have during their pregnancy now. And they encourage it for anyone that falls into basically any at-risk group, including, you know, frontline workers or anyone with an underlying health condition. Kind of similar to here, except really unless you are a healthcare worker or someone frontline worker, or you have a very severe underlying condition, then you won't be able to access it here. Whereas there you can choose to have it if you want to. So yeah, again, I really hope, my personal opinion is that we should be vaccinating all pregnant women. I just feel that the number of very unwell women we have seen with COVID-19 in pregnancy, particularly in the third trimester, is quite shocking. And I think that the potential harms of a vaccine, which, you know, is comparative to other vaccines that have been given previously in pregnancy safely. So there's no actual known harms of giving the vaccine, and even any theoretical possible neurodevelopmental effects of giving a vaccine in pregnancy. I think that is far outweighed by both the risks to the baby, because when you deliver a baby at 28 weeks, there are, you know, many significant potential lifelong impacts that can have on neurodevelopment, as well as on the physical development, on the development of their lungs, and also, of course, on the mother, and hopefully, you know, saving her life. So my own personal view is I would absolutely, if I was pregnant, get the COVID-19 vaccine in pregnancy. And I hope that we will have that ability to have these conversations with women and offer it to any that choose to take it. But, you know, we'll wait for the UCOS data and hopefully the data that comes out of Israel as well to kind of update us on that in the future. Okay, so yeah, as I kind of mentioned at the start, I think because of how the pandemic has evolved, and it's evolved rapidly, especially at the start, we have so many new statements coming out, new pieces of guidance coming out, new medical information that needs to be disseminated. And, you know, our advice to pregnant women was changing all the time. Our advice to everybody was changing all the time. Wear a mask, don't wear a mask, you know, social distance for 2 meters, social distance 1 meter, isolate for 10 days, isolate for 14 days. You know, the guidance for everything has changed rapidly. And we as a society in general have had to find new ways of communicating, and especially medical, healthcare-based information, because, you know, we heard this word a lot over the last 4 years, but fake news is everywhere. As I'm sure everyone here has seen somewhere, some rubbish that, you know, as a doctor, we are used to kind of reading and digesting information and weighing it up. But, you know, other members of the public may not have that privilege to be able to sift through what is fact and what is not. How do we communicate new medical information when it arises traditionally? Well, we've got, of course, doctor-patient interactions, but really we've had far fewer doctor-patient interactions than we otherwise would have. So yes, if you had someone coming to your clinic and you needed to advise them that maybe that drug they were on is no longer suitable for them or has a new side effect, you could tell them about it face-to-face or even over the phone, but actually you can't really rely on doctor-patient interactions on this frequently to communicate this kind of medical information. We could write to all our patients, we could send all our patients emails or send leaflets through the door. But again, it's not really practical on the kind of volume of types of medical information we need to disseminate at the moment. There is newspapers, and newspapers have been a very important tool to getting some of this information out there, as well as medical websites, so NHS UK, patient.co.uk, obviously the government website themselves, where they have a lot of the coronavirus guidance. But, you know, how many of our patients read these websites? Is this where they're getting their information from? Certainly not my kind of 20 to 40-year-old demographic. I don't think they really go on these websites to check their information. People watch TV, Good Morning Britain, This Morning, and it's great when they have a kind of good, reliable health expert on there, but sometimes they're not always the most reliable, and they often share their kind of opinions. And so, yeah, these are the more traditional ways of getting this kind of information out there. But what I want to put to you is, you know, have you considered, are you on social media? And when I say, are you on social media, I am not really referring to just, do you have a Facebook profile that you communicate with your old friends from school? I'm talking about being present on a public profile as a doctor on social media. And it's something that every one of us can do. And so I'll tell you a little bit about what I do on social media and how I use it, the benefits and also the downsides of doing so. So here we go. Some of the reasons why doctors like me and like many others that are on social media, why do they use it? So this is mainly talking about kind of a women's health field, but you know, so many women use this space for health searches, and people want them to have accurate evidence-based information. That's what led me onto social media. I would have people coming to me, you know, telling me all this stuff that they've heard from, you know, some midwife online or a doula online, which is just completely goes against everything that how we practice in hospital, is often unsafe. And I'm like, where do you get this information? And more often than not, it's come from some YouTube video or Facebook video that they've watched. And that once someone almost goes down this route, it's very hard to shift their mind. Someone comes in and says to you, I do not want forceps in any situation for my birth. And it ties our hands. It's really difficult. And we have to kind of unpick, where did you get so far down that you can't go back and see kind of all of the options in front of you. And so I wanted to be a voice on there that can provide evidence-based information that people are looking for, maybe not in the traditional places. People also use social media to make complicated topics simpler to understand, to learn from patient bad experiences and make myself a better doctor. This has been so true for me, because everything that I do on social media, I have to read up on the current guidelines. I have to read up on current papers. I get challenged on anything I say. So I both hear patients' own experiences, which informs my own practice. And I also have to kind of constantly be up to date and staying up to date. And it makes me read much more than I otherwise would. There's a kind of a desire sometimes to reach more than just the patients that you see in your hospital or in your office. And, you know, as efficient as you might be in a good day, you might be able to see 20, 40 patients, maybe, if you're, you know, really kind of 5 to 10 minute appointments. But I could write, you know, create a video or write a post, and it could be seen by 20,000 people, 30,000 people, you know, in an afternoon. So it definitely reaches more people than I could impact on a kind of in my day job. People find that it can inspire, especially if you're giving a positive view of the world of medicine, to inspire potential future medical students. Also to give a realistic picture of the medical world as well, because a lot of people that are out there sharing what it's like day to day, people over the last few years, I'm sure many of us experience kind of a reduction maybe in the amount of respect that people have for the medical profession. People are often quite combative, or maybe don't agree with things that we say. And actually, by sharing what we do in a day, people can understand more about it, and it just gives a more realistic picture, more relatable picture of the medical world. And it also can be used to kind of otherwise share fitness, wellness practices, things that you believe in yourself, and that you want to share with others. So that's just some of the ideas of why people might use social media. So me, what do I do? Because I'm referring to the stuff I do online. Well, my Instagram kind of profile name is the OBGYN mum, because I set up my account when I was pregnant with my first daughter, for all of the reasons I've just mentioned. I wanted to share information about pregnancy because I was pregnant. I had friends that were pregnant. They kept asking me all these questions. And I was like, well, why can't you just go online and look at that? But there was nowhere really to find out, you know, when should my baby start moving? You know, you could go on the RCOG website and find the patient leaflet about that. But actually, my friends weren't doing that. They were texting me and asking me. So I wanted to share a place, have a platform where people could turn to find that kind of information. Everything I share is evidence-based. It's based on the current guidelines. I actually even steer clear of sharing anything that's based on like a single study, because often, unless it's something like a systematic review or a Cochrane review or a national guideline, you know, that it can be still quite controversial. I'll try and steer clear of anything controversial and just share, you know, the real bread and butter medical knowledge that people, you know, can help them to understand their bodies, the choices they have available to them, and just basically ask any questions that they otherwise couldn't ask. So my platform runs in different ways, in different places. Predominantly, I'm on Instagram. I have a blog as well, which I kind of use to just share longer versions of things I write on Instagram, because you're quite limited to a character limit there. I run Q&A sessions once a week. I have a very small YouTube channel, which I keep telling myself I need to do more of. I do now some journalism. So I write in the media, some media articles. I collaborate sometimes, occasionally, with brands who, again, want kind of a reliable voice who can help them maybe communicate a certain message. And speaking opportunities that sometimes come up. I'm now working with the Royal College of Obstetricians as well, helping them to create videos and sharing information with pregnant women, because again, they're trying to increase their reach and how they reach people who aren't landing on, maybe on their website or seeing their doctor on a regular basis. So this is just a little example of my Instagram page where there's kind of a mixture of pictures of me and kind of infographics that I create. And they're all on various topics around women's health. This is what is an instrumental birth, conceiving after a miscarriage. Some of it is just kind of thoughts, relatable information, talking here about, you know, the struggles of secondary infertility, helping people to feel like that they're not alone. There's somewhere to talk about this stuff too, that people kind of bottle up. And even more so, I find during the pandemic, people have struggled maybe with being able to talk about things they've just had to go through on their own. Some women have been through multiple pregnancy losses during lockdown when they've not really had any friends and family to share that experience with. So yeah, there's a mixture here of kind of gynecology and obstetrics, and a bit about my own life and my own experiences of parenting. This is just an example of the blog, and again, longer form versions of the posts. This was an article I contributed recently, kind of building on one of the things I was saying earlier about how many women have been missing out on their smear tests. I was able to contribute to this article, which is all the reasons basically why women shouldn't be skipping their smear tests. So we can recognize that there is a problem here and find ways to reach women and encourage them, not just by kind of the more standard routes or by a GP calling every single woman that's missed a smear test, which is just not really that practical. So just trying to find other ways to reach women where they might be reading it. So I think when I talk about social media as a doctor, the main thing a lot of people are really worried about is, you know, well, what does the GMC say? Am I going to get in? Am I going to get in trouble with saying the wrong thing? Am I going to lose my license? And I think that's what puts a lot of people off or makes people scared. Well, the problem at the moment really is, I would say, there isn't much guidance about doctors using social media as a public profile. There is guidance about kind of, you know, patient confidentiality, but it mainly relates to how you would use your personal profile of social media. Obviously, there's things like you need to treat your colleagues with respect, so you've got to always speak respectfully on there, making sure that you act professional. And that's something that's very important to me with everything that I do, that I wouldn't necessarily post, I don't know, pictures in a bikini or something that even I'm careful to not post pictures of myself with, you know, maybe a glass of wine. Maybe one glass of wine is probably okay, but you wouldn't put up something of you being drunk somewhere or something that maybe people could, you know, it basically just looks not very professional. So you've always got to kind of have that professional hat on. Making sure that you keep confidentiality. That's one thing that they kind of go over and over in all of these guidelines. And you should just be aware that anyone you speak about on social media could identify themselves. And I'm very careful that even if I'm not, you know, I'm not going to write someone's name or date of birth that I might be referring to, but sometimes I'll come off a shift and I'll want to talk about that really complicated twin delivery that took us 4 hours and this is what happened. But actually, if I go home from today where I did that cesarean section and come home and write about it on social media, and that person could be following me, they may be able to identify themselves as being that case. So you still have to be careful in other ways. So I don't ever post something contemporaneously or really within a couple of days of something happening. I might refer to something that happened, you know, a few weeks or months ago, but maybe when someone necessarily couldn't identify themselves from that. So that's, I think, very important. The confidentiality is paramount. And obviously making sure that anything you say is factual and best, you know, and correct to the best of your knowledge. I think most of these things kind of go without saying. They comment on kind of doctors' use of social media. Again, it's really about professionalism and confidentiality is what they kind of go over. BMA have some guidance on social media, kind of covers the same sort of thing, that you should never troll somebody, that people have a right to privacy, so you maintain their confidentiality again, and how you can kind of disagree, but everything's about a professional way of doing so. I just wanted to kind of comment here about, there was a scandal. This lady is a midwife working in a hospital in London, and she had a huge following on social media. And she was known as mother of daughters, and she'd been on social media for a very long time talking about midwifery, as well as her daughters and her family life. And she kind of got very caught up in a terrible scandal, which evolved from one of these nasty kind of chat room websites where they were talking about her and her family and her Instagram. And she went on there as under a private profile. And when people were saying kind of nasty things about her, she was trying to reply, pretending to be that it wasn't her. And when they started to catch on that she was the one that was responding, she started trying to throw them off by talking about other influencers and other people on there, including making some extremely racist comments about a Black influencer. And what came out of that was that she was found out who she was, and she was accused of bullying and racism, and there was her kind of license, her midwifery license was called into question, and she lost her social media profile. It was closed down. So you know, it can go wrong, and most probably she never meant for it to get like this. She got kind of caught up in a spiral that went terribly wrong, that she couldn't get out of, kind of a web of lies that she'd spun for herself. But, you know, there are downsides. We are all human, and you have to kind of have also, you have to have strong shoulders sometimes, that there are things that can be said about you that you need to accept because you're on a public profile. Just one final bit of guidance that I wanted to mention, which is the ASA guidance, the Advertising Standards Authority, because people that are on social media sometimes might get paid for work that they do. And again, for doctors particularly, it's very important to stay up to date, that you stay within the advertising standards in terms of declaring anything you get paid to post about, declaring anything that is gifted to you or sent to you as a free product for you to try. And as a doctor, I would also encourage anybody that kind of has offers like this to be very careful about who you align yourself with, because you could be seen to promote that brand or that product. And, you know, that if something came up about that product in the future, you could be held accountable that you promoted it. I think that's particularly important, for example, with medication or anything really medication related. I would never promote publicly, because I think even if it's something as simple as paracetamol and it's particular branded paracetamol, or I got asked if I would promote some iron tablets that was marketed at pregnant women, but you know what, we shouldn't be encouraging anyone to use any specific brand of iron tablets. It should be anything like that should be on the advice of their own doctor or of a pharmacist who are able to give that kind of information. And I don't think there is a place for it really on social media. So I kind of mentioned a few of the downsides already of having a public profile of social media. Criticism, it comes all the time. It's obviously time consuming. People can criticize and control you and send you nasty messages. Some people kind of ask me, how do I feel about a lack of privacy? Because I have some of my private life on there. But as I've been doing this now for a little while, I'm sharing less and less probably of my family life. I used to at the start share pictures of my children, but now I don't. That's mainly because I worry about security for them. I worry that they could be recognized if they go to a particular school or nursery, that they may find out, you know, our address, could rob us, that kind of thing. So I keep the children out of it now, or show the back of their heads. You're under constant scrutiny. Every single thing I write, I will get comments on, people either agreeing with it or sometimes disagreeing with it, or pointing out some tiny detail I might have missed out, probably because I didn't have enough characters to include. But there's scrutiny to everything. Potential conflicts of interest, especially if you are monetizing stuff that you're doing. And I mentioned before, you know, the possibility of kind of scandals arising, and you're in the public eye. But yeah, I would say when it comes to social media, it's not all bad. I might have painted a bit of a negative picture here, but I love it. I get huge satisfaction from it. I have, you know, messages from people telling me that whatever I said, even if it was months ago, made a big difference to the birth that they had, or, you know, that encouraged them to go and speak to their GP about some abnormal bleeding they were having, and that led to a diagnosis of something that they've been putting off for many years. So I do feel a big sense of reward, and I really do enjoy it. And the longer that I've been doing it, the more I've been able, in a way, to balance it in my life, because I've learned how to section it off. Like, I'm on a post nights week this week because I was on last week. So I've got some days, I'll batch prepare some content, which will keep me going for the next couple of weeks if I have busier days as well. So things like that help me to balance it so it doesn't feel so overwhelming. And sometimes I just don't care if I'm not on there for a few days. You know, life takes over, family comes first, and, you know, social media will still be there another day. I don't really care about follower numbers or about being consistent anymore. I just do it when I feel that I can add something valuable to somebody, or I've got something to say, really. So if you're interested in getting started, the first thing I would say is just go for it. Don't think about it. Don't worry too much. Pick a name, something that people can identify you from. Don't go too wide. Don't try to be everything to everybody, because first of all, it can feel completely overwhelming. And when it comes to any form of social media, this is whether it's YouTube or Instagram or Facebook or wherever you are, or TikTok, it's good to stick to a consistent niche so people know why they're following you, what they can expect from you, and you can interact with other people that are in the same space as you. Check with your defence union what you're doing. I didn't really mention the defence unions actually earlier, but they're really important. At the start, I spoke to the MDU and they were happy to cover what I was doing. Then earlier this year, I spoke to them again, said, just so you know, this is what I was doing. And they said they were no longer happy to cover anything to do with social media. So I had to take out separate insurance to cover me for that. So I think it's really important to check with your union whether or not they'll cover you. It tends to also become more of an issue. I guess the bigger your platform grows, the more that you're doing, and potentially if money is involved and it becomes work and you're also working as a doctor, then you might need separate kind of insurance for that. Keep an eye on like the feedback from how posts have gone and use that to guide you. So there are metrics you can tell when you make a post, how many likes it's got, how many people have saved it, how many people have even sent it to their friends. And those kind of things tell you if what you're doing people like, if it was valuable or not. And that can help to guide you to make more of the same kind of thing. And the other thing is to remember that, you know, social media is all about being a community. It's about interacting with other people and collaborating and working with them. So comment on other people's things, support everybody, be a cheerleader, and they'll do the same back to you. Ideally, be consistent. If this is something that you want to do, you do need to invest some time in it. You can't do it one day and then come back 3 months later, especially when you're starting out. Posting, you know, a couple of times a week will help you to see a return on the time that you're investing as well. But also I would say, if you can't be consistent because you're busy with other things, don't let it stress you out, because these things can also kind of add to the mental health burden as well. So yeah, I hope those tips might be helpful. That's pretty much all I have got to say. I think I've said a lot of things on a lot of different topics. So yeah, I am very happy to take questions on anything really.
Well, thank you very much, and thank you for a discussion at many different levels, where there are lots of questions that arise. Obviously, I've got a couple on the vaccine one, which came in beforehand, and just to go back on them, the question of are there any long-term effects and and is there any difference between the AstraZeneca and the Pfizer with regard to pregnant women? And is there any particular group of pregnant women you would say, no, you definitely must not get the vaccine? Those three questions, and then I'll come back to some of the others.
Yeah, so I guess taking the last one first of all, and I think there was a worry that we shouldn't give the vaccine to people in their first trimester, or people who, you know, could be pregnant or conceiving at the time. Again, that guidance has changed. So that came out at the start, and they were saying, you know, if you're going to get the vaccine, wait 3 months before conceiving. Now there is no guidance around that. I think, as far as I am aware, the only group that can't get it really is people that have a history of anaphylaxis, and I think that particularly relates to the Pfizer vaccine. Otherwise, no, I'm not aware of any group that specifically can't get the vaccine.
Right. Okay. And then during the course of the pregnancy, do you think that the second vaccine makes any difference? Timing it's given.
So as far as I understand it, at the moment, we're still giving it at the recommended interval, the 12-week interval. And because I particularly feel it's important that we make sure we reduce the impact of the likelihood of anyone catching COVID-19 in the third trimester, I would personally encourage people to get both doses, 12 weeks apart. If you're going to delay the second dose, until we know whether that affects your immunity or not, if you were to delay it, let's say you had your first dose at 12 weeks and you waited 6 months for the second dose, whether that would mean that if you were in the third trimester, you may still be likely to catch COVID again because your immunity level drops. I think at the moment, I would just take it at the recommended intervals. We're not recommending delaying delaying beyond 12 weeks, the second dose.
There's a big urban myth everywhere about fertility, that having the vaccine affects your fertility. It's not only the question of how you answer that, it's the question of how you structure the answer to that as well. Yeah.
I tend to keep it short. There is absolutely no evidence for this rumor. There is not even really any theoretical basis for which it could affect fertility. So yeah, I would be, I guess you could probably structure a longer answer, but mine would be quite short. No, there is no evidence for this.
Right. Okay. And then there's also there's the question on the social media side. You mentioned the question of confidentiality, and obviously that's the high priority in the guidelines. If you're talking about individual cases, how does one ensure confidentiality? Isn't there somebody, the one child in Great Ormond Street who had X?
I mean, because when I'm using social media, I am trying to have kind of the greatest impact to the greatest number of people. I don't tend to focus on the extremely rare conditions. My audience is interested in far more common things, something like preeclampsia or something, about bleeding after, hemorrhage after birth or something like that, something that's likely to happen to them. I do steer clear really of the very rare conditions. And I can't think of a time really I've discussed a single case, because why do we discuss, a single case? It will probably be because there's some sort of like medical learning from it. What is the general public going to gain from that? And if they're not really going to gain anything particular, then I don't think there's any benefit of sharing it as a particular case. Sometimes something will happen that will stimulate me to want to talk about a topic, complication that happened in a cesarean section. But I wouldn't then say, oh, earlier today we had a bladder injury during a cesarean section, so I want to talk about how likely it is that you have a bladder injury in a cesarean section. What I might, at some point just maybe come up with a reason that, that I might talk about it. And I wouldn't describe that one case, because I don't think that's going to benefit that group. It helps us as clinicians to have a full case presentation. But to the general public, where you're just trying to get across, a key message, I don't think it's necessarily that helpful.
Right. Then another related question is, what was the reason that the defense unions had a view that they no longer covered? There's the view that the doctor is always the doctor, and therefore you covered holistically. And on the other hand, there's a view that this is a different kind of activity. What was their comment?
Yeah, I think it comes as a different type of activity. Normally, their insurance to you is based on your activities in a hospital on a kind of doctor-patient individual basis. And so whilst we all, we exist as practitioners outside of our daily practice, and you're, your uncle or someone you meet at school might ask you a medical question or your medical opinion, and you can of course, you know, have a conversation that involves giving some advice around a topic. We all do that, and that's normal, and that's, you know, that's always been allowed. And so of course they accepted, you know, we would cover that, just in the same way you can go on the news and talk about coronavirus, because you're not providing a kind of a clear, direct doctor-patient interaction whereby someone is relying on you for your medical advice. But I think, yeah, probably the scale of it and the possibility of a volume of complaints coming in was maybe what worried them. I still don't really know. They just kind of came back as a no. And I've got a couple of other friends who are doing the same thing. And we all at the same time asked all of our defence unions, so it covered all of them, not to name any names. And all of the three big names of medical insurance said no to covering this type of work anymore.
Right, okay. What about the question of publication of material, of any material within the medical journals? The cheaper the freebie medical journals, but I noticed you mentioned the Huffington Post, but you don't mention Pulse, for example, or and the question of the fact that that to a certain extent the major medical journals like the BMJ do publish commentary, this kind of commentary, which you do you have any interactions with them at all?
Yeah, I mean, in the same way, I think, I mean, I haven't not recently published something in the BMJ, but like, yeah, I think there's no harm. Any of us can write for those kind of things as doctors, giving our medical opinions, and we are covered by our defence unions in those situations, which is why I was surprised at the start. And they did cover me for the first couple of years. I think it's probably the business side of it, and working with brands, for example, that probably made them it more complicated. Because my main worry was, for example, someone saying, I'm talking about having a vaginal birth after cesarean section and why, let's have a positive birth experience, and they might go off and try to have a uterine rupture and then come back in and say, well, it's because I watched that IGTV video of you and you were saying how great it was, and then they could kind of sue me for something I say. But like you say, yeah, it's probably the same is true, could be possible with any medical journal anywhere. But yeah, I think I'm still not entirely sure why they said no, which is why I say just to check with your own union. It's new, and when you start saying things like social media and you're not saying the BMJ, I think they just get a bit more worried.
Okay. I mean, there's another question. I mean, which has been raised is the question about kind of you're doing an enormous amount. You're managing to juggle really a medical clinical career, a writing career, and a mother. How do you manage, and what are the lessons that this might apply to other people who would like to do the same?
Well, I mean, I think probably everyone on here juggles a lot. I don't think I'm any different or any special. I think just because some of the work that I'm doing is quite public, we as clinicians, we are used to keeping a portfolio and doing audits and things that we maybe, has to be done outside of our day-to-day work. And so I think it is something that probably everyone here is used to working outside of working hours. And I think, yeah, probably I've been quite structured now in what I prioritize and what I do. And sometimes I do let the social media fall by the wayside, but I do try and plan ahead. That is probably the main thing that I do now. If you don't plan ahead, it can feel very overwhelming and scary. Whereas if I already have my next post written, even if the kids are paying up at bath time and, I've got to get my portfolio ready for my ARCP or whatever, I can say, I don't need to worry. I can just push that post out and think about it again when I next have time. But also I have to say, I don't have free time. I don't have downtime. I don't really watch Netflix. I probably do this every evening when I come home from work, have dinner, put the kids to bed, and I work until I go to bed on this stuff. But that's how my life is now. But Shabbat, you know, I can say this, we're a very Jewish group. Shabbat is really important to me and has become probably more important to me since doing this work, because I switch off completely. You know, I'm not even that religious, but my phone going off is really important because it's my time away from it. So I do have like 24 hours a week where I have nothing to do with it. And that probably saves me again, because I come back on a Sunday and I'm like ready to go. I kind of miss it. I've got things to say I might have been thinking about. So yeah, I don't know if there's already kind of helpful tips, but that's some of how I manage it.
Well, on that kind of lesson, I think conveying the Jewish lesson as well as the parental lesson as well as the doctor lesson, I think that's a very good point to say. Thank you very much for a very interesting and very enlightening presentation. And we look forward to hearing more about how this progresses in the future.
Thank you very much. Thanks again for the opportunity.